This lecture will cover Chapter 7, the general considerations for continuing care for a neonate. Thermoregulation is very important when caring for a neonate, regulating the baby's core temperature. Core temperature should be maintained at 37 degrees Celsius, which is 98.6 degrees Fahrenheit. Newborns have a diminished shivering response and must rely on the metabolism of brown fat for heat production. Problem is, brown fat cells don't start appearing until around 26 to 30 weeks gestation. So when you have a neonate that is preterm earlier than 30 weeks, we have to really be concerned about their ability to maintain their core body temperature. Brown fat is stored around the great vessels, kidneys, scapula, axilla, and the nape of the neck. When brown fat is broken down in order to produce heat, we call this non-shivering thermogenesis. So the creation of heat by a non-shivering mechanism. So in addition to those neonates that are preterm and we're concerned about their ability to maintain their core temperature, the way that we protect them and to keep that core temperature at that normal level is to put them in some type of thermal apparatus. Some places use saran wrap to keep the heat in. Others have a more elaborate system that will kind of put them in like an insulated looking pouch, so to speak. And the goal is to allow the baby to maintain that core body temperature at a normal level, but where they don't have to utilize their own brown fat stores to do so. That suit actually acts as a conduit to. Okay, we just talked about how to regulate body core temperature. Now we're going to talk about the ways that you can lose heat. And there's two gradients that the body core temperature can lose heat. The first is the internal thermal gradient, or ITG. And the internal thermal gradient is nothing but the difference between the temperature at the body core and the temperature on the skin. So heat travels from warmer internal structures to the cooler skin when we're talking about heat being lost through the internal thermal gradient. And there are many factors that will affect this occurrence, which are metabolic rate, the amount of subsequent fat that is present, the amount of surface area for heat dissipation, and then the distance from the body core to the skin's surface. Now, we're concerned with this with all babies, but the ones that we are most concerned with are preemies, because a premature neonate has a diminished ability to maintain their own ITG for one major reasons, because they have a large amount of skin surface area, but they don't have a lot of body weight. So this results in a large area for heat to actually dissipate. The premature neonate has relatively thin layer of skin and decreased amounts of subcutaneous as well as brown fat stores. Consequently, it has less insulation to prevent heat from being lost. Additionally, the brown fat stores deplete rapidly if they do actually have some stored up, depending on their weeks of gestation. And this will result in a loss of the ability to generate heat through utilizing the non-shivering thermogenesis. Another factor is that the preemie is often unable to take in enough calories to maintain the level of nutrients for heat production. As you know, neonates, even when they're breastfed, it takes a few days before they actually may be getting real milk from the mammary glands. So their nutrition is of concern early on. And if they're not getting the nutrition that they need, then they won't be able to break down those calories. They won't be getting in enough calories that need to be broken down to maintain their body core temperature by producing heat. So the metabolic response of the preemie to cold is impaired also by hypoxemia. This presents a problem because most premature neonates suffer from some degree of pulmonary problems leading to hypoxemia. It's pretty common occurrence when you're a preemie. You're going to have problems regulating your use of oxygen. So this presents a problem because most premature neonates suffer, I already said that, frequent handling, which is often required in the care of the preemie, disposes the patient to the cold environment outside the incubator. So that's another reason why when you're dealing with neonates that we do touch times, meaning that all of the healthcare professionals kind of coordinate together when they're actually going to go bother the baby, so that we're all doing it at the same time or right behind or in front of one another, instead of the constant 1 hour it's this person giving a med, then the next hour we're giving a breathing treatment or suctioning them out. So we try to leave the baby alone as much as possible, and then when things need to be done, we try to coordinate them so that they're all being done around the same time. Now, external thermal gradient is a way that heat can be lost, and it is the temperature difference between the skin and the environment that the baby is in. So the external thermal gradient is also called ETG. And ETG is determined by environmental factors, obviously, that are controllable by the healthcare professionals in that area. So the four main factors that the NBRC loves to know that you are aware of are radiant heat loss, conduction, convection, and evaporation. Those are the four ways that a neonate can lose heat by external means. So you have to make sure you know what those are, and then because you focus on knowing what they are, you know how to avoid those things happening to the baby. So that is your goal when you have a neonate. You want to reduce the amount of radiant heat loss, conduction, convection, and evaporation that is occurring. Because again, we are the ones that are controlling this. Okay, now we're going to break down the different types of heat loss. Radiant heat loss, think about waves, heat waves coming off the baby, electromagnetic waves. You can't see them, but the heat from the neonate will dissipate or move from the baby to a cooler object that is near the baby, but not directly touching the baby. So there is no direct contact, but the cool object is close enough to the radiant warmer that the heat will want to move from the baby skin to the cooler object. So you can't see this happening, obviously, because electromagnetic waves can't be seen, but it is happening because you have a cool object near. So that can be, say, a laryngoscope and blade. If it is not touching the baby, but maybe in the warmer or near the warmer. Anything that is cool, the most common concern are AC vents. If a vent is near the radiant warmer, then it obviously that cool air can draw heat from the baby. Okay, conduction is the next one. Conduction is the transfer of heat from the skin to cooler surface that is actually in contact with the neonate. So the cooler the surface, the more heat is actually lost. And conduction of heat can also occur in reverse if the surface is warmer than the skin. That heat from the surface can then go to baby and make baby warmer. So it can add to heat production or heat loss. So conduction is when heat goes from the skin or from an object that is warm to an object that is cooler. We don't want cool objects in contact with the neonate. That is why when we accept the baby from once it's delivered and we have that receiving blanket, we wipe the baby down real quick and discard that blanket immediately once we get over to the radiant warmer, and we start with a new one, so that all that fluid that we just wiped them off with, that will be a cool, have a cool type of temperature in comparison to that radiant warmer that we bring them over to. We don't want the baby's core temperature to go down because they're losing heat because of the cool liquids that we just wiped off of them onto this blanket. Convection is the next one, and that is loss of heat from the skin to the air current passing over the neonate. With convection, the velocity of the temperature of the air determines the amount of heat loss. So the convection is the principle behind wind chill factors, which makes temperatures colder in a wind. It's all about the movement, the velocity, the movement of the temperature, not necessarily the temperature itself. As you know, you can be in the Windy City and the temperature can be the same as it is here in Atlanta, but because the wind chill factor that they have that we don't have here, it'll be much colder. So it's all about the movement of that temperature when you're talking about convection. Also with convection, heat transfer via gas involving a mixing of cooler and warmer air is facilitated by the movement of air. So as air velocity doubles, the cooling effect is squared. I know that's all mathematical and algebraic, but basically if you increase the speed, if you double the speed, then the effects that you have on cooling the baby or losing heat is squared. Natural convection occurs as less dense air expands and rises, and then forced convection occurs as air currents are generated by external forces such as a fan. And that's what we're concerned about, the forced convection, where neonates, especially preemies, are concerned. Last but not least is evaporation, and evaporation is the release of heat due to water changing from liquid to gas. This is a very, very important concept because this is the common heat loss that the NBRC likes to see if you understand. because as respiratory therapists, we deal with liquids and gases all the time, right? So this can be either insatiable from the skin and respiratory tract. You can evaporate or lose heat because liquid is evaporating from your skin, and actually as you exhale, you are also losing heat due to evaporation because that's liquid as well. Or it can be sensible heat loss, such as sweating. So when you have water molecules on your skin from sweating, the way that you actually lose the heat is because the water molecule will evaporate on your skin, and therefore the end result of that evaporation is heat loss. So heat taken from a surface that is required to change a given amount of liquid into gas, that is the definition of evaporation. The heat taken from a surface that is required to change a given amount of liquid into gas. Transepidermal water loss, which is just another fancy word for evaporation. Transepidermal water loss is an example of the type of heat transfer that occurs during evaporation. Okay, as we've been talking about thermoregulation, it is important to remember that being too cold or too hot is a bad thing for a neonate. Cold stress or hypothermia is of concern because one of the main reasons why hypothermia begins is because vasoconstriction is occurring, peripheral vasoconstriction, in response to the cold temperature. And that will shunt blood away from the skin. And if blood is being shunted from the skin, that means there's less oxygen getting to the skin, and therefore those tissues experience hypoxemia. The blood will be hypoxemic in that area, and then of course the tissues will experience hypoxia, and also acidosis due to the anaerobic metabolism, because when oxygen is not readily available for metabolism, then the body will use lactic acid, and the acidosis is the end result of that. While all that's going on, the body wants to compensate for the heat loss, and it will then trigger a non-shivering thermogenesis, which is the use of the brown fat stores. When your body utilizes its brown fat to produce heat, that results in hypoglycemia because you are utilizing sugars as well to get that energy. So anytime you metabolize anything, you use up sugar because that's part of metabolism. And when you use up the sugar and you're not able to recreate that insulin in response to that, you get hypoglycemia. So cold stress is a very common concern that we have with neonates. It can be initiated by opening the incubator doors or some cold gas blowing onto the neonate, maybe from a flow inflating resuscitation bag, not self-inflating. Obviously, you know, self-inflating won't have anything coming out the end until you squeeze it. It may also be triggered by placing the neonate on a cold scale or maybe a countertop. So we as healthcare professionals can minimize the amount of cold stress that the neonate experiences. So with cold stress, the cold environmental temperatures for the neonate may be uncomfortably warm or even hot to the adult. However, the neonate may be cold. So just forewarning you, when you work in a neonatal intensive care unit or in labor and delivery, especially labor and delivery. Don't anticipate wearing a lab coat. I know that we require it as a student, but t-shirts and all that stuff under your scrubs, it may be a bit much. You're going to feel like derobing, especially when you have multiples and several different people in the room. The more people that's in there, the warmer it gets, but they're trying to create an environment that is suitable for neural temperatures for the neonate. So with the cold stress, the initial response to the hypothermia, as I mentioned earlier, is vasoconstriction, which will cause the blood to shunt from the skin. And this, what I didn't mention earlier, is this helps to maintain the internal thermal gradient, the ITG. The peripheral vasoconstriction, however, will lead to anaerobic metabolism and metabolic acidosis, as I mentioned earlier. Hypoxemia acts to further restrict the neonate's response to the cold stress and worsens the acidosis. Simultaneously, the hypothermia triggers non-shivering thermogenesis, which boosts heat output. With the increased metabolism of brown fat, glucose levels begin to fall, potentially leading to hypoglycemia. The combination of peripheral vasoconstriction and brown fat metabolism causes the neonate's body temperature to remain homeostatic for a time, but if the stress is corrected quickly, the patient may suffer no permanent effects. A continued cold stress, however, may lead to the deterioration of the patient's condition and possibly death. A neonate who is being continually cold stressed may maintain normal body temperature, but at the expense of critical calories that are needed for growth. Now, with hyperthermia, you end up with peripheral vasodilation instead of constriction. And this helps to dissipate the heat. So you have dilated vessels, you have more blood flow to the skin, and therefore the ability for the radiant heat from that blood to dissipate through the skin to some external object. This increases metabolism and oxygen consumption and may result from things like infection, dehydration, malfunctioning, incubators, radiant warmers, humidifiers, phototherapy. All of those are reasons why your neonate might experience hypothermia. In the delivery room, we have to be mindful of regulating the baby's temperature to prevent evaporative heat loss. It is best to completely dry the neonate immediately after delivery with a pre-warmed blanket and or towel. Be sure to get their head and face, as those areas are particularly important. To prevent radiant heat loss, make sure to place the baby under a radiant warmer for the head to toe examination. And once you're done examining the baby and doing your assessments, then wrap the baby in a warm blanket and place a cap on its head. To prevent convective and conductive heat loss, you need to keep the neonate covered as much as possible. And then for small preemies, they need to be placed on warming mattresses and in pre-warmed incubators. For thermoregulation in the nursery, you want to be aware of the difference between incubators and open warmers. Depending on their baby's needs, they will either be in one of these two types of cribs. So you have incubators. The advantages of an incubator is it has a controlled thermal environment to regulate the body core temperature. But the disadvantage is you have less access to the patient. You can access the patient, but you have obstruction to your access. And then an open warmer, the advantage is that you have readily available access to the patient with nothing impeding your ability to get to the patient. But the disadvantage is you cannot control the temperature. So for incubators, temperature is regulated by servo control. You're going to put that electrode on the skin, and it uses the skin's temperature to then determine whether the heat of the incubator needs to be increased or decreased. The skin probe must be secured to the skin. This is one of the major sources of malfunction. So if you have to troubleshoot, always check the sensor that goes on the baby's skin to monitor the temperature of the skin. Okay, for open warmers, you want to keep the baby wrapped when possible. Okay, for the last slide, we will talk about behavioral-based care. And this care is concerned about the times that you will stimulate the patient. The sleep-wake state means that you will only stimulate the baby when he or she is alert. Awake, not alert, awake. Activity level is another one. Depending on how active the baby is, will determine whether you will stimulate the baby or not. So if they're not active, then no stimulation. You can only do things that you can observe. No touching of the baby or manipulating the baby. Approachability. Some babies are just not approachable certain times of the day, or maybe right after they've had a feeding. The lights are too bright. There's different varying different reasons why a baby is not approachable at certain times of the day. But knowing that about the baby and communicating that with all the healthcare professionals allows you to base your care on that particular behavior of that neonate and work around that. And then O2 status. If the baby is desatting, you do not want to stimulate them as much as possible. Rather, you want those babies to try to decrease their activity level, so in hopes that they will utilize less oxygen stores, and therefore their O2 status can go back to a normal range. So that is extremely important. You will see once you do a NICU rotation that they utilize these behavioral-based care and scheduling things around those situations is extremely important, and may even be something that is driven by the therapist. It just depends on the facility. So that concludes our discussion on Chapter 7, General Considerations of Continuing Care of the Neonate.